We're joined by a special panel of experts, Alison Pittard, who is a consultant in intensive care, our own Dr Zoe, and top virologist Natalie McDermott, who is actually rushing to the studio as we speak. Hopefully she'll join us in a few seconds. Alison, let's start with you. You're an intensive care consultant. Yep. Can we cope? Are we ready? We were looking at the pictures from Italy yesterday of exhausted staff over there, asleep at their laptops with bruises on their faces because of the mask they've been wearing for 6 hours, couldn't eat, couldn't go to the loo. How prepared are we?
I mean, everyone is worried about what's going to happen, and we can see from Italy what the worst-case scenario is going to be. But everybody is discussing what we should be doing. The NHS is always prepared for emergencies. We have very rigid strategies in terms of implementing changing the way that we work, expanding beds, getting extra staff in, etc. So they're all well rehearsed. And back in 2009, when we had the swine flu pandemic, all those strategies were put into play and we managed extremely well. One of the problems we've got at the moment is that over the last 10 years since swine flu, we've had a gradual increase of about 4% every year of demand for patients needing to come to intensive care. But what we haven't seen is the same increase in the number of beds in intensive care capacity. So we're starting off in a worse place now than we were then. So although we've got the strategies, we know what we need to do, we don't know if we'll cope. But what I can say is that anyone that needs to come into hospital, anyone that needs to go into intensive care will get a first-class service from the NHS.
And a lot of people, you know, those lucky enough to have private healthcare will be thinking, well, I'll be all right because I can go into a private hospital. But actually, they're not ready and set for this at all. No,
I mean, there have been discussions with the private healthcare sector to see how they could help the NHS. But the majority of emergency care happens within an NHS hospital. So there may be places where some private hospitals can help in other ways, but not for the emergency patients, particularly those that need intensive care, because in the UK, the majority of intensive care services are within the National Health Service,
It's a balance here, isn't it? And you said then, we think we're ready. And I think we're all grown-ups. We want honesty. We want to be told the truth. And at the same time, many people feel very anxious about it and don't want to be scared unnecessarily. And that is quite a tricky balance to strike, isn't it? It's going to be tough.
It is. There's absolutely no doubt it's going to be tough. But what we will need to do as doctors, nurses and the whole team that works together is change the way that we work. Because the way that we work now is, you know, how we feel is best for every single patient as an individual. We're going to be looking at different things. We've got to make makeshift intensive care units. We're going to have wards with, you know, positive patients. That's not the way that we normally work. So we'll change the way that we practice so that we can cope with, you know, what we expect.
There's been some talk of bringing people out of retirement, doctors, medical staff to help with this. I mean, is that an option?
That obviously has been discussed, and I don't know exactly how far those discussions have had. But, of course, people who've retired are older. They may already have, you know, problems with their health. So that puts them in a category of increased risk. And also, the longer it is since you've retired, you don't keep up with your profession. So you may not have the appropriate skills and knowledge, etc. But what they may be able to do, if they wish to come back, is help in other ways. So not have the direct patient contact, but be able to support the healthcare team doing other things. So they may well have a very valuable role to play.
Front line, Zoe, I mean, you're sitting there, you got this surgery. So what are people coming in for? Are you sitting there thinking, oh, you shouldn't be here, you're wasting time? Or are you thinking, you should be at home, you should be dialing 111?
Well, what we're asking people to do, if they have any symptoms that could be COVID, is not come to the practice. They can call us, but ideally they should be using the 111 service, who have done amazingly well, by the way. They deserve, you know, praise from all of us because the capacity of work that they're dealing with is huge. So the advice for people is, if you're not sick, but you're worried and you want advice, to use the 111 website, because as you can imagine, the phone lines are very busy. But actually, if you think you may have symptoms that could be coronavirus, then dial 111 and speak to somebody.
First symptoms, though. First symptoms. I mean, maybe I'm being paranoid, but, you know, we're trying to do this, continue every day. We're both in a sterile bubble. You know, we've got you know, wipes everywhere. And that's not just for us. That's if you've got it, then you don't want to pass it on to somebody else. But what about, you know, sort of taking your own temperature? Is that a first sign that there could be something going on?
So up until now, what we've been saying is a fever and a cough are likely to be the first signs of this virus.
So why are people at borders being checked with the temperature?
So that's to check for a fever, see if they have a high temperature. I think what we're realising, though, is like all viruses, cough and fever are the commonest symptoms, but actually there are people who've tested positive who haven't had any symptoms. There are people testing positive who've had a sniffly nose or have had other symptoms. I think we're going to see the guidance change, and I think what's likely to happen is we're going to be asking people to self-isolate if they have any symptoms, if they have any upper respiratory tract.
Natalie's just arrived now. In you come, Natalie.
Hi,
Natalie's
Natalie.
a clinical lecturer at King's College.
Will you just move up a little bit, Zoe?
She's
Sorry,
specialising in paediatric infectious diseases. Thank you very much indeed for coming in. Yesterday, the World Health Authority declared this a pandemic, which sounds very frightening. What does that mean?
Well, it doesn't mean anything practically different in terms of how we're responding. It just means that they now define it as an infectious disease that is spreading worldwide. And I think the definition basically says it has to be spreading from person to person on the majority of continents in the world.
And so should, you know, public events start being cancelled? Should schools be being closed? There's so many rumours flying around amongst us parents about when the schools are going to close and what that means for all of us.
Yeah, so the definition of it being a pandemic doesn't necessarily change things for the UK. What changes things for the UK is what's happening in the UK at the moment. And so there may be decisions based on the number of new cases increasing each day that are made in the COBRA meeting today that change things. But there won't necessarily be a blanket policy of all schools in the UK being closed or anything like that, because some of it comes down to a risk assessment in each individual region. So if we saw one region having lots and lots of new cases, then it might be the government decides to close schools in that region. But that's not a blanket policy that covers the entirety of the UK.
Well, you're sort of an expert on viruses and the travelling nature of viruses. So this morning we find out that for the next 30 days, Donald Trump has suspended travel to America from 26 European countries, but not including the UK. Sensible?
Well, I think that the problem is that, one, travel bans often are not that effective. Italy implemented a travel ban when the situation was largely limited to China, and look at the situation now. Because that travel ban was implemented, they weren't monitoring people so much that came into the country, and they weren't asking them to self-isolate. So we had a lot of transmission in Italy, likely, before they ever detected any cases. So that's something that indicates that travel bans don't necessarily work. I think the situation in the US now is they already have significant person-to-person transmission in the US. So the implementation of a travel ban from Europe is unlikely to have significant impact on the course of the outbreak there.
You could fly from Paris to London and then from London to America, or you could come in on the Eurostar from somewhere in Europe and then you could carry on to America. I mean, it seems like it wouldn't work right from the word go.
Yeah, it's difficult to know, isn't it? And as Natalie says, it hasn't worked in other places.
Yeah. So this COBRA meeting that's today, the UK is expected to move into the delay phase. What does that mean?
So that's where there may be the introduction of things that can limit the spread of the virus in groups of people. So it might involve stopping certain public gatherings or sporting events. But each of those will be made based on a risk assessment of the risk that poses to the public and the transmission. Right. It might also include the closure of schools. But again, in specific regions...
Like you said before.
Yeah.
Okay.
Is there a possibility that we could get to a stage, like we've seen in Italy, where nurses, doctors, consultants have to choose who they save?
Doctors and nurses make those sorts of decisions all the time.
But not on this sort of level?
No, not. But we have very clear ethical and professional frameworks by which we make decisions, and it's really important to make the right decision for the patient that's in front of you. And I think one of the most important things that should happen is that we all should have conversations and think about what we would want. So particularly older people that do have chronic health conditions, what would they want, irrespective of coronavirus?
Are we talking about DNRs here?
No, we're talking about... It's about shared decision-making. So, you know, if you forget coronavirus, we should all have a clear understanding about what we want to happen to us.
So when we go in, it's OK to let me go?
Yeah, I mean, I wouldn't want that to happen to me because I've got a lot of life to lead. But the important thing is if somebody goes into hospital...
I think, and you are professionals, we admire you enormously. It's a fairly controversial thing to say because I could be 83 and have COPD, but I have a lot of life to lead.
Exactly. And that is exactly what I mean. Because some people would say, if you're this age and you have that disease and you have that quality of life, we shouldn't be treating you. But that's not up to us to make that decision. That is up to the individual. So we would want you at 83 with COPD to say, I've got a fantastic quality of life, I want to be treated, because that is the right thing for you. But if you don't have the conversation with your family, if you come into hospital and you can't talk to us, how do your family know what you would want?
Zoe.
I think these are the types of conversations that we encourage families to have with individuals who are perhaps in their last 12 months of life anyway. So I think what we're saying here is this is something that might start those conversations. The coronavirus epidemic might start some of those conversations, and it's a very small number of people we're talking about who perhaps are likely to succumb to something in the next 12 months if they were to get coronavirus. Would they what? But it's a very small number. I think something that's really important to say is that our healthcare system here is very different to Italy. We've had so much prior warning. We are armed and we're ready.
I'm worried that just here now, and I think I probably would be reflecting what a lot of people watching would maybe thinking. This is the first time we've almost heard of survival of the fittest.
Well, that isn't what I was saying. What I was saying was we need to make sure that we know what individual patients want from the NHS. And if you don't have the conversation and think about it in advance, we're guessing.
I think it does raise an important point, though, that we keep hearing that young, fit, healthy people will get a mild illness and be fine, and we should be concerned about those who are at high risk. And we should. And I think I'm not scared for me. I'm not scared for my 10-year-old nephew. I'm not scared for my dad because he's in good health. But I am afraid for some of my patients. And it takes all of us to do the right thing, which is actually at the moment to follow the advice that's coming out of government, all of us to do the right thing to protect those who are vulnerable, and it's important that we all do that.
You get a sense, we've been sitting here on the sofa talking about this for weeks now, and so it's our daily conversation, as it is with the entire country. But you get a sense that something's changed today, actually. It's like it went up a gear this morning. Where will we be in a week?
Well, I think that's difficult to say, but I think we can certainly say the situation is going to get worse before it gets better. But what's important is that if we all take on our responsibility as an individual citizen in the UK to do what we can to protect ourselves and to protect others, and yes, that might involve making some sacrifices. Yes, it might involve making some decisions that we don't particularly like, but it's a small decision for us. But altogether, that makes a huge impact for the rest of the country.
Decisions like what?
Decisions like, I don't feel very well today, so yes, I could go into work, but I'm not going to. I'm going to stay at home and I'm going to work from home if I can, because I'm not going to expose people on public transport. I'm not going to expose people in the office. And part of that isn't just about, could I be infected with coronavirus? It's about, could I be infected with any virus? Because right now what we want is to offset the pressure on the health service. So, yes, if I get a cough and a cold virus, I don't need to go to the doctor or go to hospital. But there are vulnerable people who, if infected with it, might need to. So whether I have coronavirus or some other virus, I'll stay at home, I won't infect other people, and that will stop vulnerable people getting infected, and it will offset that pressure on the health service.
All right.
Thank you.
Thank you
very much.
Thank you for your hard work.
Yeah,
Thank you very much
absolutely.
indeed to you and all your teams.